So Professor Galea is Dean and Robert A. Knox Professor at Boston University School of Public Health, has held academic and leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. He's published extensively in the peer-reviewed literature, a regular commentator in a range of public media about the social causes of health, mental health, and the consequences of trauma, and he's been listed as one of the most widely cited scholars in the social sciences. So I'm absolutely delighted to invite Professor Galea to open our conference and talk about economic, social, traumatic stresses and population health. Thank you very much, and thank you for joining us, Professor Galea.
Well, thank you very much, Professor Morgan. Thank you, everybody, for being here. The center, I must admit, is my favorite center worldwide, because when I first approached about it from Professor Morgan and heard about it, I thought those are exactly the kind of things that I've been concerned about for 20 years. So I'm really delighted to be here today. Let me share my screen. So what I'm going to do in a brisk 25 minutes is I was asked to sort of talk about this topic, which I think is very much on all our minds, which is the notion in a time of COVID about economy, social stressors, traumatic stressors, and how they affect population mental health. And a lot of what I've been doing, and Professor Morgan was very kind in pointing out in my book, really is about trying to change how we think about mental health. And notice that there's the word population here in my title, that fundamentally I'm going to push us to think about populations. And I'm going to make an argument, a science-based argument, as to why we should think about population mental health, and then I'll take some questions. So having said that, let me plunge in. I just want to start with traumatic stress science. Now I could spend an hour talking about traumatic stress science. I'm not going to do that, but what are some of the foundations, just so that we're all on the same page about traumatic stress science? This is a definition of trauma. It comes from a book. There are many different ones, but fundamentally, traumatic events are events that can cause psychological harm, and they are events that are threats to our safety and the stability of our world, which of course, everybody here realizes is exactly what COVID has been, which of course, everybody realizes why this topic is so important in a day like today. Summarizing a whole course of graduate learning, the fundamental observation about traumatic stress science is that the more traumatic events one experiences, the worse it is for one's health. It is actually that straightforward. This looks at lifetime traumatic events and depression, showing a very nice dose-response relation. And I could sort of show you many slides that show that, but fundamentally, traumatic stressors are harmful for our mental health. Now, disasters, just to bring those in, are really large-scale traumatic events. They're traumatic events that typically have acute onset, and they can be any range of causes, natural, technological, or human causes. The reason disasters matter in our conversation about population mental health and traumas and stressors is because disasters are increasing worldwide. This looks at the number of natural disasters worldwide. Now, why are disasters increasing? Well, for two reasons. One is global environmental climate change, and two, urbanization. We have more and more of us living in cities, and these cities are affected by global environmental climate change, which means that disasters are even more important to our mental health worldwide. And the reason they're so important is because they're very large scale. This is Hurricane Katrina, which was a major disaster in this country where I live about 15 years ago. And the reason I'm showing you this is because these were the areas of the United States that were declared a disaster, had a disaster declaration when that happened. And that is entirely the size of the United Kingdom, where most of you are. So it's really just to give you a sense of how large scale these traumatic events can be. And of course, we're now living through COVID, which I would argue is a large scale traumatic event that is affecting all of us at a very large level. And when these events happen, they have broad scale mental health consequences. This looks after 9/11 in New York 20 years ago, the Twin Towers terrorist attack, and really showing the studies that were done that showed the prevalence of post-traumatic stress in the whole area. The Twin Towers were right here, but this is New York, New Jersey, Long Island, Connecticut, all having prevalence of higher post-traumatic stress after that particular traumatic event. And the other thing of note about the consequence of these events is that these consequences last a long time. This is from a study that was done in the Netherlands about 20 years ago. And I show this because I think it's the best study out there that uses electronic medical records to show that yes, a traumatic event happens, there's an increase in mental health conditions, but what's key is that while they go down, they stay above baseline for many years thereafter. So really, that's just a whirlwind tour of traumatic stress studies in 3 minutes, but I just wanted to bring us all on the same page, because if we are to talk about population mental health in the context of traumatic events and stressors, we need to understand what traumatic events do to mental health. Now, let's move on to thinking about individuals and populations. This is the point about thinking about populations, not about individuals. What do I mean by that? Well, schematically, I can think about a population this way. Population is this population of sort of gray figures here. What we typically do in our biomedical model is we tend to think about a group of patients, people with diseases, so sort of people here in the blue in the corner. That's not what a population health approach does. What a population health approach does is it thinks about the whole population, thinks about everybody who's in the population, and recognizes that there are many people with some sort of illness in the population, and we try to reduce the number of people with illness. That is a dramatically different approach than the patient-focused approach. And this is not an anti-patient focused approach. This is simply an approach to population mental health that I would argue subsumes a clinical individualistic approach. Because when we think about individuals only, very particular things happen. And those of us who have spent a career in mental health know what those are. One of the things that happens is we end up using more drugs. This is the increase in antidepressant use among adults in the United States, females, males, and overall, an increase over the past 20 years. And I can show you this in many different ways. This is ADHD, anxiolytics, antidepressants, antipsychotics, all increasing over the past 20 years. Because when we focus only on individuals, when we focus on a clinical approach only on the people sort of in the corner, the blue figures that I showed you there, focus only on patients, we make this cognitive error that Mario Balotelli, who was a soccer star for many years, playing with Manchester City in the UK, made here. When Mario Balotelli was scoring goals, he had the sort of the amusing arrogance of sort of lifting up his t-shirt to say, why is it always me? Why am I always the one scoring goals? Of course, then he left Manchester City, which is a great team, and went on to other teams, and his career has essentially gone down the tubes. Because really what he was forgetting is that while he was the one scoring goals, he was really part of a team, and that's ultimately what made him so successful. And I think that is fundamentally what we need to think about, and that even if we think about individuals, we need to recognize that they are part of a population-based construct, which is inevitable if we are to understand population mental health. So having said that, having framed it, how can we think about populations, and how can think about populations help to understand mental health? And I'm going to suggest 5 principles about thinking about populations. These principles derive from my book called Population Health Science, which I did with my colleague, Dr. Kerry Keyes. And it's not a mental health book, it's a general book about population health, but these principles apply very well, I think, to mental health in general, and in particular at this time of COVID, which I'm going to make some examples and illustrations about that. So number 1, when we think about population health, we need to think about multiple levels and forces accumulating over the life course and over generations. When I talk about multiple levels, I think that's captured best by this very simple diagram from Professor George Kaplan, which says that my mental health is, yes, due to my individual risk factors, but those are linked to my social relationships with you all, the living conditions where we work, the neighborhood and communities in which we work, the institutions within which our neighborhoods exist, and the laws and policies that shape those institutions. And our health and our mental health is inextricable from all of these levels, that it is simply unavoidable that we should think about mental health as a product of all these levels. That's step A, multi-level. Step B is over the life course. We accumulate risk over the life course at all of these levels, from prenatal level all the way to older age. Mother's nutrition, infancy, separation from her parents or violence, adolescence, social supports, adult life employment conditions, older age, social isolation, access to care. All of these forces matter. All of these forces fundamentally shape our health. And it is simply a not helpful reduction to not think about these forces. And I'm going to show you in a second mathematically, both at multiple levels and across the life course. I'm going to skip these 2. Number 2, population mental health is multidimensional. Notice I put the word mental health in here because while we are here because of the Center for Society and Mental Health, fundamentally these principles apply to health more broadly. Mental health is not exceptional in that way, but I think what's relevant to those of us in mental health is that we often have not thought of mental health in this way. So I'm trying to bring mental health into population health thinking and bring population health thinking into mental health. Now, what do I mean by multidimensional? We are used to thinking of mental illness as you have mental illness, you do not have mental illness, as a categorical outcome. That is simply incorrect because health is not a categorical determinant. Health has multiple dimensions. Here's an example of that. I'm looking here at body mass index, just to focus. We tend to think of body mass index and obesity over BMI of 30 or under BMI of 30. But that, of course, elides the full shape of the distribution of BMI among people who actually do not have, quote unquote, are not living with obesity, so to speak. But look at the shape of the distribution and look at how that has changed over time. These are from 2 national surveys in the United States, one 40 years ago and one 10 years ago. And while you can see the cutoff, which is the orange line here, and you see people to the right of the cutoff, there are more people now who are living with obesity than there were 40 years ago. But the distribution behind that has actually quite changed, meaning that there are now more people who are closer to the line than there were before, which changes how we think about the whole notion of how many people and their body weight and their distribution. That applies equally well to mental health. So while I can show you data from studies we've done and others have done, showing that there's been a 3-fold increase in depression in time of COVID as a direct result of the COVID stressor, what I think really matters is not that. What I think really matters is this, which you seldom see in papers, which is that the population distribution of symptoms has shifted to the right. The orange is COVID, the blue is pre-COVID, and what you see is there are more orange bars moving to the right, which means there are more people with fewer symptoms and more people with more symptoms, which means that while there may be a 3-fold increase in the categorical diagnosis of depression, there are more people who've now had more symptoms who are now at greater risk of depression in future, and for whom, without meeting a categorical definition, that is still affecting how they live and affecting all other dimensions of their life. And I can show you that with other disorders. This is people with and without post-traumatic stress, again, also in time of COVID. The blue line is with PTSS, the orange line is without post-traumatic stress symptoms. You see the shift to the right. More traumas, more stresses people experience, they have more symptoms across the board. Even if I were to create a cutoff here and say people with and without PTSD, you have a shift of the entire population distribution of post-traumatic stress. So second point, multidimensional. Third point, ubiquitous causes. Ubiquitous is something we don't hear very much in, when we talk about mental health, but here's the metaphor for ubiquity. The metaphor is the goldfish metaphor. Goldfish are surrounded by water, and the water, of course, influences everything they do. You can focus on exercising a goldfish, giving them the right food, but unless you change their water, the goldfish are never going to be healthy. That is similarly the case when we think about health. There are ubiquitous forces, and these ubiquitous forces shape everything about our health. Let me just show you, I'll stick a little bit with the body weight example. This is a bookshelf of books on diet and exercise, which you can find, and there's a lot written about the role of diet and exercise in shaping body weight. But of course, what we tend to forget is what is ubiquitous. What's ubiquitous is the change in caloric intake due to changing calories for simple foods. Bagels were 140 calories 20 years ago. They're 350 calories today. Muffins were 110 20 years ago. They're 500 calories today, which means that I, the same human 20 years ago, eating the same bagel and eating the same muffin, got far fewer calories than I'm getting now. That is a ubiquitous force. And of course, other ubiquitous forces in this domain are the availability of healthy food outlets. This is New York City by zip code, showing the tremendous heterogeneity in neighborhoods that actually have food available to them. And of course, also heterogeneity in educational level. This is a map of absenteeism in schools that suggests that people are better or less educated in terms of able to make food decisions. These are ubiquitous forces. In the context of mental health, in the context of stressors, we know that the better the economic indicators there are, the lower the rate of population suicide. Now, we can look to spend a lot of time focusing on individual drivers of suicide, but we also know that general population economic function is protective against suicide rates. And of course, in the time of COVID, now this is American data, we have had tremendous drops in employment, and those drops in employment have been unevenly distributed. It's the poorest 25% of society that have had a drop in employment that has persisted in the American context, while the wealthiest 25% of society has actually recovered quite well. So knowing that the ubiquitous force of economic indicators is ultimately what drives things like poor mental health and consequence of poor mental health like suicide, that is also now being stratified into groups that are the haves and have-nots are widening as we have disadvantaged the have-nots even more. And I come back to depression after COVID. While I showed you there was a shift in the population distribution, and I showed you there's a 3-fold increase in COVID, what I didn't show you is that that is not even. This 4 groups of people in the American population divided, focus only on the extremes, focus on the left and on the right. There is a 4-fold difference in prevalence of suicide between the group on the left and the group on the right, of depression, I apologize. The group on the left are the group with assets and low stressors. That means groups with savings, with wealth, with stable housing, not being worried about where they're putting their kids in school. That group has 4-fold lower prevalence of depression than the group with low assets, with no savings, who are unstably housed, who did not have reasonable wages, who had a hard time with their kids in school, hard time looking after their parents. Fourfold different on depression in the context of the stressor that has been COVID. Fourth principle, when we tend to think about from a scientific point of view, and of course the center is about science, we have a temptation, almost a compulsion to think about deterministic causes, to isolate causes, and to say, what is the one cause of poor mental health? Let's think about that one cause so we can act on that one cause. And that thinking, unfortunately, leads us down wrong paths. And when we think about populations, we have to recognize that we actually need to think differently and need to think better. So let me, you can all still see the slides, okay? Okay. So let me pose this question. How much is our risk of depression determined by our genes? Let me make this premise. Let me give you this premise that there are two things that matter for our depression, our genes and our environment, and they both matter together, genes and environment. I'm going to be simplistic here for the sake of math. There's a gene, just calling it a gene, and some environment, and they both produce depression if they act together. So given that, I'm going to ask you this question. What % of your depression risk is due to your genes? And now if we were together in person, and I hope one of these days or years we can be together in person, I would ask you to write this down. Write down what % of your risk of depression is due to your genes, given the assumption that genes and environments matter. I'm giving you a second to think about a number in your head. What's % of risk of depression due to your genes? Okay, now let me show you the math behind that. I'll go back to a population of gray figures. And my notation is as follows. In this population, I have a certain number of people, and they're always going to be the same, who are marked as black, and these are people with the depression gene. I realize there's no depression gene, but I'm doing this for ease of mathematics. So the figures marked in black are always depression gene positive. The figures marked in green are in an environment that generates depression. So the figures marked in green, environment generates depression. Figures marked in black are gene depression positive. And the black plus the green are going to create depression. Depression is going to be marked as red. I have these 5 here, these few red figures that are already there to show some depression before I even start my experiment. So let's do this experiment. Let's start with this scenario where the entire environment almost is marked by the depressogenic environment. Now remember, there were the genes, which were the figures marked in black. I've now put them back in here. I've just made them as dots just so you can see them behind the green. But what I said is the black plus the green is going to create red, which is depression. So from this experiment, what is the proportion of the risk of depression that's due to the genes? Well, everybody who had the gene became depressed. Did you see that? So the relative risk, you can do the math, is 334. And the population attributable risk is 1, which is 100%, because everybody with the gene became depressed. So the answer to the question I posed, what % of your risk of depression is due to your gene, is 100%. But not so fast. Let's take a different experiment. The same gene pattern, you notice the same pattern of black figures, but now a different environmental pattern. The green is only on the right. Only a couple of the figures with the black with the gene are under the figures in the green, and the black plus green become red. Now, in fact, most figures with the gene do not have depression. So the relative risk of depression given the gene is 1.7, and the population risk proportion is only 40%. So when I ask you the question, which is what % of your risk of depression is due to your genes, given the condition that genes and environment both matter, while you may have written down a %, the only correct answer would have been, I cannot answer that question unless you tell me also about the environment. Which is why, of course, population mental health is so grounded in the environment. Why does this happen? Because under the assumption of co-occurring causes, you cannot tell between samples unless you understand other factors. Now, I know you're thinking, well, that's all nice and theoretical, but what does this mean in practice? Well, in practice, it means things like this, that while we understand that the serotonin transporter gene is a gene that matters for depression, when you do meta-analysis, you find the results are all over the map because these analyses never take into account environmental factors that affect populations. When you do things like this is a mega-analysis, billions of dollars in mega-analysis of GWAS studies for major depression. These kind of mega-analysis find things like this. Although the largest genome-wide analysis of depression yet conducted, we're unable to identify robust and replicable findings. And the reason is that we are not taking into account the other factors that shape mental health in populations, which means that you simply cannot ignore the environment in which populations live and within which mental health happens. And the key here is it's simply not good enough to say, well, we understand the environment matters, but let us just isolate this particular cause. The key is that actually, if you don't take the environment into account, you are going to be making mistakes in your science, which means that when we have a time of COVID, this is Times Square in New York City, which is famous for its New Year's celebrations. On the left is New Year's in 2019. On the right is New Year's 2020. Just give you a sense of the difference in Times Square. Living in a time of COVID, COVID has been the ubiquitous exposure, and we simply cannot understand mental health in any population worldwide without understanding the impact of traumatic stressor that has been COVID. And my fifth and last point is the centrality of health equity. We cannot think about population health without thinking about health equity, health in general or mental health specifically. Now, when we think about health equity, it's important to recognize there's a lot of complexities around health equities. We can think of money interventions that improve overall health, but actually widen equity. This is an illustration of when you intervene, you have DALYs here, disability adjusted life years, and we're doing an intervention which adds 1 DALY per 50. Well, the 50 and 25 gap becomes 51, 25.5. If you introduce 10 DALYs per 50, you go 60 and 30, inequality of 30. And often we have interventions which take populations which are equal and then they become unequal. Now, by going from 50-50 to 60-55, we've increased the overall average, but we've widened health gaps. And we have to recognize that whether our priority is widening health gaps or increasing overall population health is a matter of values. And for those of us who think about population health, we need to recognize that it's a matter of values. It's very important that we ground those values and change the conversation around health so that we can have honest conversations about which value animate what we do. And we are seeing these same issues in the context of mental health worldwide. This is Hong Kong, where I've been involved in a research group doing some work here, looking at depression after COVID and after the civil unrest there's been in Hong Kong. And all I want to show you here is, again, these 4 different groups with more depression in the group with high unrest and high COVID, but in particular, the group with low assets is the group that ends up having high mental health, poor mental health. And this is data from the UK, from Public Health England, showing percent of respondents with high anxiety, which is a dose-response relationship with income. So I think those 5 principles ground how we think about mental health in populations, and ground in particular how we can think of that in the context of population stressors. So I'll conclude about what are the implications of a population mental health approach, because I think that the population mental health approach has real implications for how we think about intervening. So let me take a population. Again, I'm going to a population now, and that by population has the blue, who I'm calling unexposed, and the red exposed. So it's just a reductionism for utility, but essentially the people in the red have had greater exposure to stressors. Let's say they have more economic stressors or more traumatic stressors. The people in blue have some, they just have fewer. So we have some sort of dichotomous marker of poor mental health that affects the whole population. That's the X's. The reds have more X's, but there are also X's in the blues, right? The reds are at higher risk by our typical language. Now we can convert that into this. This is a risk factor, that's the prevalence of poor mental health. And you can say, which is what we typically do in mental health practice, is let's take the people with the more risk, with more stressors over a certain line, and just deal with those people. And if we did that, in theory, we would deal with the burden of mental health, poor mental health, and the people to the right of the line. But if we did that, here's what we're doing. We are dealing only with the red people, the people with more stressors to the right of the line. We are ignoring all of those people who are the blue people who also had excess. I think a population mental health approach has to be different. It has to look at the whole population and fundamentally aim at shifting the curve of mental health in the whole population. And if we did that, we take the whole population and we fundamentally, by taking the whole population, we are reducing the number of people who are red. So to create a better and healthier population and have fewer of the axes. So I think an economic traumatic stressor approach to mental health, which is what I was asked to speak about, which makes a lot of sense in the time of COVID, is a perfect illustration of the challenges that we have in terms of thinking about population mental health. And I think it's a perfect illustration of why we really cannot create better mental health unless we think about populations. I will stop there because I want to leave a few minutes for questions. Thank you very much for having me. So I saw a lot of questions in the chat. Craig, I will address these unless you want to address them.
Well, just to come in, Professor Galea, just to say thank you so much for such a wonderful and perfect introduction, setting the scene for what we hope will be the conversation that we have through the conference. We do have time for questions, and just from looking at the chat, and you could pick up on any questions that you want to as well, Sandro, but I guess there are two things that stand out for me. One relates to resilience, and one relates to how do we actually change people's minds on this. The question in relation to resilience is really about the idea that there's an expectation that some people should be resilient, and your thoughts on that. And then secondly, in relation to how we can shift the conversation, I guess that is something that ultimately will be on everyone's mind as we progress through the conference, is how do we do things? How do we actually concretely shift and shift politicians' ideas around these sorts of things?
Well, let me address both. I think resilience is something that's obviously talked about quite a bit in mental health, and my ask is that we shift our conversation away from the notion of individual resilience to the notion of population resilience. And I worry if you Google resilience and resilience in mental health, what you find is a number of, like really a lot of individual approaches that fundamentally are pointing the finger at me and telling me what I need to do so I can be stronger. And that is simply an wrong thinking. Resilience, if you understood my talk, resilience is ultimately a population level phenomenon. Resilience is a bouncing back of a population. And we cannot have population mental health resilience unless we invest in creating a world where there are fewer economic and traumatic stressors. Now, that's not to obviate the role of individual agency. This is not an or argument, but it simply says that we vastly overweight on the individual's responsibility. We almost sort of make it as though the individual has a responsibility to be resilient, when in fact we should be leaning on creating societies and communities that allow people to be healthy. Now, in terms of the conversation, obviously, Craig, this is how you framed what the center does and what these next couple of days are about. Increasingly, I feel like the way to change the conversation is by having the conversation, by having exactly this conversation, and by having this conversation over and over again. And sometimes I think the danger that we have is, we're talking to ourselves here in this room, and for many of us, this may be something, well, this is roughly how I think. There's nothing new in my thinking. But we forget that you leave this room virtually, and this is actually quite radical thinking. So I do think that this requires a real shift in thinking around policymakers and in the public conversation in the media, until I sort of feel like we have not achieved this until at every kitchen table, when somebody's asked, so what is it that best generates your mental health? That the answer, that sort of grandmother's answer, is not my doctor, but it's the politics and policies in my house around me. If my grandmother could say that, then I feel like we've arrived, and it's going to be a long way for us to get there.
Thanks very much, Sandro. It's such a nice way to think about it when you have a conversation around the dinner table. What is the answer from people that you're close to on these sorts of questions? I wonder if we can squeeze in just another question, and apologies to all those who have put questions in that we may not get a chance to get to. But there's a question about the potential role for social theory in understanding how the environment affects population mental health. And so again, it'd be useful to get your thoughts on that, Sandro. So what is the, and I guess this will be of interest to a lot of people attending the conference, what's the role for social economic critical theory in understanding these impacts?
Yeah, I think social economic and critical theory are really important ways for us to ground how we think and to organize our thinking to the end of doing the science and scholarship we need to do, to the end of generating interventions. I think we have to be careful that, sometimes I think we all of us, we sort of fall in love with our theories, and I think that's a bias and a caution which I just want to insert there. But I actually think it's really important that we organize our thinking correctly, and in some respects, population health science thinking is a conceptual frame, right? It's theoretical framing that says, let us think about the world in a particular way. The way we think about the world, and this is why Craig was very kind to sort of showcase my previous book, and the subtitle was what we need to talk about when we talk about health, because I think fundamentally that means changing the frame. And changing the frame, that means having the theoretical perspective that creates the space for population mental health thinking.
Wonderful. Well, thank you very much, Sandro. What a really great way to open the conference and to begin that very conversation about these sorts of issues. And where we hope to end up in 3 days' time is with exactly those sorts of questions of how do we then move forward? How do we take action, and what are those steps that we can do to concretely shift the conversation? I'm afraid we do have to close the session now. It would be great to continue to talk, and there's lots of questions. We need to think about how we can ensure that those questions are captured and fed into the conversation, that there's opportunities to pick them up in further sessions.